in a young talents like completed our DM along with an experienced people, Dr. Rama Madam, Dr. Mahesh, and all others who are really going to give in a pulse of rheumatology, which is the need of the hour. And most of the time, rheumatology is our president rightly said, this is one of the most neglected, and also it is an upcoming specialty. Thanks to our national president, Dr. Upender ji, coming out with an excellent module. That's really the need of the hour. That's what our president is clearly put it, how IAP cares for the specialty which needs to be given importance with the people like Dr. Vijay Vishwanathan. With these few words, wish you all the best, Dr. Yashwant and team, for planning out an excellent scientific program. I can see Dr. Sanjay Srirampur sir, Pranam sir, and all other senior members so who have been joined to this important program. Thank you very much. Wish you all the best, Dr. Yashwant.
Thank you, sir. I request Surender sir, the convener for this year program, to say a few words and then hand over to Rama madam.
Hello.
Yeah, Surender sir.
Yeah, good evening. Good evening, Dr. Sen.
Yeah, sir, Surender sir.
All the panelists and
yeah, sir.
The moderator, Dr. Rama. Good evening, all of you. We are very happy to start our Telangana program again on the web link. And today we are having a rheumatology session. I wish you all the best. Happy learning. Thank you, Ashwan. I request you to kindly continue the program.
Yeah. Sir, Sanjay sir, a few words of your wisdom, sir. Sanjay sir. Sir, Sanjay sir, kindly unmute, sir. Yeah, sir. Satish, kindly unmute Sanjay sir.
Yeah. Very happy beginning for Dr. Yashwant. I think it's very appreciable that Yashwant has started his program even before inauguration, even before installation actually, because academics are more important than the other functions. So, and he has also started with a topic which is very pertinent actually, which is often neglected in pediatrics. It is the need of the hour. Wish you all the best, Dr. Yashwant and his team. Wish you all the best for the coming year. Thank you so much.
Jagdish Chandra sir, to introduce the panelists and.
Right. Thank you, Dr. Yashwant. At the outset, I would like to thank PATS and Dr. Yashwant for giving us this opportunity to chair this very important session on rheumatology. As you are all aware, rheumatic diseases are defined as a constellation of results of the physical examination, autoimmune markers, and then we have got serological tests, tissue pathology, and imaging. But in the absence of the specific diagnostic criteria or specific signs, single signs or screening tests, it becomes very difficult for us to diagnose a particular type of a rheumatic disease. And the presence of the varied symptomology resulting in overlap syndromes makes it all the more difficult for us to diagnose a particular type of rheumatic diseases. So it is imperative that we try to give more importance to the clinical findings which are available over there and then start investigating. Unfortunately, these diseases have got a long-term effect and are chronic diseases, and they have got to be tackled on a child, family, centered chronic illness method of treatment management. It has got to be a multidisciplinary approach to these diseases. So I would like to introduce our panelists who are there, who are going to give us their pearls of wisdom on rheumatology. We have got a very good panel over here, which consists of Dr. Rama, who is going to be the moderator. She's a consultant with Vijay Mary Hospital, and she's known to me for quite a long time. And then we have got experts, Dr. Anjani Gummadi, Dr. Kavita, Dr. Fani Kumar, and Dr. Mahesh. I would start introducing the panel. Dr. Mahesh Janardhan has got his MD, MRC, PCH, FRC, PCH, CCT, and MSc in rheumatology. He is an associate professor of rheumatology in Apollo Children's Hospital and Kanchikoti Kanchikoti Children's Hospital. He has got several national and international publications and is the winner of Paul Bownes-Weger Gold Medal in 2018 and Dr. Lalita Kameswaran Best Paper Research Publication in 2021. The second speaker is going to be Dr. Fani Kumar, who's done his MD and DM, and he has done his DM from Nizam's Institute of Medical Sciences and is an associate professor of Department of Rheumatology in NIMS. He's got nearly about 20 publications in national and international peer-reviewed journals and has contributed about 6 chapters in national textbooks. He's got a special interest in primary systemic vasculitis, Takayasu's arthritis, anti-neutrophil cytoplasmic antibodies, inflammatory myositis, anti-synthetase syndromes, MDH5 dermatomyositis, and lupus. So we have got these 2 speakers whom I'm going to introduce. Regarding the other 2 speakers, I think my co-chairman is going to introduce them. Yashwant, Dr. Yashwant.
Dr. Ramesh is there in the group. Dr. Ramesh, please unmute yourselves. Ramesh, sir.
Yeah, he's there. Unmute yourself, Dr. Ramesh.
If there is any technical slack, Rama Madam, kindly introduce now. Please go ahead.
Yes. Good evening, everyone. First of all, Happy New Year to all the office bearers, Central IAP as well as PATS. I thank PATS team for giving me this opportunity. I'm very happy to be the moderator for a session on rheumatology. I myself have been associated with rheumatology for more than 1.5 decades. So I'm very happy to see that there are so many even young rheumatologists and pediatricians who are now taking up rheumatology and developing pediatric rheumatology as a bigger specialty. It gives me a great pleasure to introduce our panelist, Dr. Anjani. She has done her MD Pediatrics from PGI Chandigarh. She is a silver medal awardee for MD Pediatrics. She has also done her DM in rheumatology and clinical immunology from PGI Chandigarh. She has more than 40 publications in national and international peer-reviewed journals. She is also a reviewer for national and international journals. She has contributed to book review also. She is a member of various international organizations working in the field of clinical immunology, immunodeficiency, and pediatric rheumatology. Her special interests include Kawasaki disease, primary immunodeficiency disorders, autoinflammatory syndromes, childhood vasculitis, childhood autoimmune diseases, and arthritis. Currently, she is a consultant rheumatologist and clinical immunology at Ankura Hospital for Women and Children at Hyderabad. Along with her, the 4th panelist is again Dr. Kavita. She has done her MD Pediatrics and she has worked in government setup. She has then done Pediatric Rheumatology Fellowship from Nizam's Institute of Medical Sciences, Hyderabad. She is currently working as Associate Professor of Pediatrics, Nilofer Hospital. Her special interests are JIA and lupus. So with this, we have this varied, experienced panelists, both in government and private setup. With their vast experience, I think they will teach us how to approach a case based on symptoms, how to diagnose, how to manage, and look at what are all the differential diagnoses. So without wasting time, I think we'll start with the case-based presentation so that we have more time for discussion and for learning, so that we can carry home those messages throughout this year. I now call upon Dr. Mahesh to please start his presentation. We are starting with arthritis, which is the one of the most common symptoms associated with a rheumatological disorder. Over to you, Dr. Mahesh.
Is my screen visible?
Yes.
Okay, good evening to all of you. First of all, I'd like to thank you for having me in today's session, and Happy New Year to all of you. I decided to take this particular topic, systemic JAA. The reason being is that this is one of the most common conditions. Can I request the host to actually unmute the other people? I think there's a lot of disturbance.
Mute. Dr. Mahesh, please unmute yourself.
No, actually, I was unmuted by the host. That's why. Okay. Yeah. So I thought I will talk about systemic JAA. Actually, the reason being that this is one of the most common conditions that a pediatrician would see in practice. Compared to all other types of JAAs, a child with fever is most likely to present to the general pediatrician. And therefore, I decided to present this a very interesting case. And it's basically just to tell us, give an idea as to what can happen with prolonged steroid treatment to a particular child. And the previous, about 30 years ago, rheumatologists were known as steroid and Brufen doctors. It is not the case. Actually, there are so many drugs which have evolved over the last century, lots of disease-modifying agents. And in this particular century, we have, biologics, and then you have JAK inhibitors, all that's come into the scene. And they have actually changed the outlook for these patients. In the West, actually, you can hardly, if you go to an outpatient pediatric rheumatology clinic, you will hardly ever see a child with the deformity. Unfortunately, in our country, we are still seeing them because they present to us, they refer to us quite late. And even again, the complication that you're going to see again today, again, it's all because of prolonged treatment with the unnecessary drugs when other options are available. I'll start with the case. Actually, I can't.
Satish, can you help, sir? Satish?
I can't change the screen.
Satish? Yes, sir, you can go ahead.
Okay. So this is a boy who was 14 years old when he presented to us last year. He was accompanied by his mother. He came from Ariyalu. This is actually near Trichy, the central Tamil Nadu, from Tamil Nadu. So he was referred to us by a general pediatrician. This particular pediatrician, he had just completed his diploma in pediatrics in Child Trust Hospital in Chennai, and he had gone over to practice near Trichy. And this lady, she brought the child, her son, to this pediatrician, thinking that he might be able to do something for her child, because she's been going to many places in and around Trichy, but she's not been able to get a good treatment for her child. And that's the reason why she went to this person. And he referred to us thinking that there was something grossly abnormal with this child. So child obviously had poorly controlled juvenile arthritis. So the history, at the age of 5 years, in January 2012, he was diagnosed initially as incomplete Kawasaki disease at a private hospital in Trichy. At that time, he presented with fever, rashes, lymphadenopathy, and echo showed some mild coronary dilatation, and therefore diagnosis of Kawasaki was considered. He was treated with IVIG and steroids. However, when the steroids were weaned, then the fever came back again. And then the diagnosis was revisited, and then it was changed to systemic arthritis, systemic JA. He was restarted on steroids and oral methotrexate, and he's been under the follow-up of one particular specialist for a very, very long time. So for the past 9 years, the treatment that he's been on tablet prednisolone for 7.5 milligram in the morning and 5 milligram at night. Folic acid once a week, 6 days a week. Methotrexate initially started on 5 and then increased to 10 milligram oral methotrexate. And he was getting naproxen on a SOS basis. And what the mother used to do was, whenever he had intermittent symptoms like little fever or joint pain, she just used to increase the steroids by herself whenever he had some joint pain or fever. And general examination wise, we noticed that he had hypertension, but otherwise no abnormality in general examination. And head-to-toe examination, he had a muddy conjunctiva, Cushingoid facies with buffalo hump and moon face, acanthosis nigricans present in the axilla and the neck. And he had very active arthritis involving his wrists, elbows, knees, and ankles. And he had restriction of his hip joint and the C-spine. So restriction of the C-spine can also, apart from ankylosing spondylitis, you can also have that in bad systemic JAs also, and polyarticulars. So this was a picture. Remember that this is a picture of a 14-year-old child. So he's a 14-year-old showing Cushingoid features. You can see the buffalo hump on the right side. And his weight was 23.5 kilos against an expected of 46 kilos, less than the third centile. His height was 100 centimeters as expected of, opposed to an expected of 159 centimeters, less than the third centile again. And because he was relatively short for his height, he actually came into the overweight category when the BMI was calculated. So this was how he looked on the growth chart. You can see that where he's lying very grossly, both for the the height, weight, and the BMI. I mean, they're all very, very abnormal for his age. That's why it was falling. Investigations wise, he still had he had anemia. His white cell count is 32,000. This is after 9 years of treatment for systemic JAA. His polymorphs is high, platelet count is still high, ESR and CRP still high, and ferritin still elevated. So showing that all the blood tests showing that he still got very active arthritis in spite of all the treatment that he had. I can't change the slide again, sorry.
Satish, kindly help, sir. Chandrakiran?
It's stuck again.
Satish?
It will be from the server side only, sir.
So Chandrakiran? It was. I'm able to do it now. So the diagnosis was he had systemic JA with poorly controlled disease, and he had side effects, or you can say the toxic effects of steroids, short stature. We had referred him to the ophthalmologist, and they found that he had glaucoma, and he also had hypertension. So the management, what would have been ideal for this child would have been that he should have been started on biologics, and we would have wanted to wean his steroids very rapidly, and we would have managed his comorbidities. And his methotrexate, we changed it to subcutaneous methotrexate, and we increased the dose appropriate to his weight. But in this child, we were not able to start him on biologics initially. So what happened was we stopped the night dose of steroid first. He was receiving 7.5 and 5. We stopped the night dose. We changed the oral methotrexate to subcutaneous methotrexate. And we also started him on some thalidomide. Thalidomide is a drug that we use sometimes, though normally people don't use it. We use it sometimes when people can't afford biologics. For the systemic symptoms, we use thalidomide in pediatric rheumatology. And we used it in this particular case. So what happened was, during admission, this is how the blood test looked. And the right side column, you can see after 3 months, though there was no big dramatic response, we can see that actually his white cell count had reduced a little bit. His platelet, there was a little bit response. His ESR had dropped. But he still continued. This was not enough. This is not enough for a child of who's been chronically suppressed with steroids, and we want something to actually take him off the steroids. This was not actually enough. So we wanted to do something for this child. This is how he looked when he came to us. On the left side, that's the mother. She's actually a coolie laborer working in the farms. And this is a boy. And just to compare, just to show how short he was, I just took a picture with him in that. At this point, in fact, this boy was one of the reasons, or you can say he was an inspiration for us to actually start a trust in Chennai for poor children with rheumatic diseases. And actually, two chartered accountants in Chennai, they were very, interested in this particular project. And they came forward, they and another cardiologist from Tanjore. We all came together and we formed this trust. It's called Alliance for Rheumatic Children, or the Arch Trust. And he was the first patient to benefit from the trust. So what we did was, we stopped his steroids completely, very quickly. We started him on IV tocilizumab. The pediatrician who referred this patient to us initially from Trichy, he actually took an active part in helping as well. So he administered these drugs locally. So the child didn't have to come to Chennai from Trichy every time. So this pediatrician, he actually administered the tocilizumab, and he was doing it on regular basis, and he was doing it free of cost again for this child. We continued with the weekly methotrexate, and he's off steroids now. So what happened now? It's almost since a year since we first saw him. You can see that his profile is completely normal now. His white cell count, his polymorphs, platelets, CRP, ESR, all that is completely. And he's actually grown a tiny bit. I know this is not going to help in his long term. From 100, he's grown 3 centimeters in 1 year. So, and you can see how he's now. He's back to school. Look at how abnormal he was looking on the left side. Now on the right side, in spite of his short stature, he's in fact lost more weight compared to the left, but this is a healthy weight for him. He's able to walk to school, which is 2 kilometers away from his house. And so this is a big change that we're able to make to this one particular patient. So we'll talk about systemic JA, only this type of JA here, because this is the type of arthritis, as I told you previously, this is one particular JA which is going to come to the pediatricians, general pediatricians. And the most other types are probably going to land up with the orthopedicians or with the rheumatologist. So systemic JA, the International League of Associations for Rheumatology, they classify JA into 7 types, and systemic JA is one type. So it's not just, JA is not just one disease. There are many types, and systemic JA is just one. So the difference of this arthritis compared to the other types of arthritis is that, this is one particular arthritis which is more like auto-inflammatory rather than autoimmune. So you don't have the presence of antibodies, and it's just auto-inflammation. So inflammation happens on its own without the presence of anything to induce it. No autoimmunity. So it's auto-inflammatory disease, and not all the patients will always present with the characteristic features of fever, rashes, and arthritis. And the main problem comes to pediatricians when only the fevers are the presenting manifestation in these children, and they may be the only presenting manifestation. However, sometimes in some children, there may be a history of rashes, the early part of the disease. And whenever that rashes occur, it's important to take a photo of that rashes, which will help with the diagnosis. If you're going to refer to a rheumatologist later, then giving that photo will be very useful to the rheumatologist. And this is one particular arthritis which will need extensive investigation, because in India, any child presenting with fever, first we need to rule out our tropical infections first. And then again, this is a diagnosis of exclusion. There's no single test that is going to help with the diagnosis. So we need to rule out other conditions. So any other conditions, things like infections, malignancies, primary immunodeficiencies, all these things need to be ruled out before you actually make a diagnosis. So according to the criteria, you need to have arthritis in any number of joints. With fever should have been there for at least 2 weeks duration. And in that 2 weeks, you need to have quotidian fevers. Quotidian fevers, daily fever for at least 3 days in those 2 weeks. And plus you need to have one of the following, which is an evanescent rash. It's described as a salmon pink rash that can come and go, generalized lymphadenopathy, hepatosplenomegaly, and serositis. And there are some exclusions. I won't go into those too much into these details now, lack of time. And this is the typical quotidian fever. The fever spikes and then comes down, touches the baseline, even goes below the baseline. The difference between other systemic infections and systemic JA is that in systemic JA, the child will be very well when the fever is down. You will see the child playing in the ward, running around in the ward. When the fever is up, the child will be sick like, like as if the child has been like any other infected child. But the moment the fever comes down, the child will look completely normal. And the rashes may come with the fever and go. In infected children, you will see that even if you try hard with paracetamol, the children still look sick until they are completely well. Whereas that's not the case with systemic JA. And this is just an example to show the typical salmon pink rash of systemic JA. You can see that. The differential diagnosis in systemic JA is extremely broad, but in our country, we need to remember first is bacterial infections, any other sort of chronic infections, and TB particularly, and malignancy is one particular thing that we need to definitely rule out. Before we start steroids, we need to be 100% sure about the diagnosis, especially in case of malignancy, because if we make a mistake and we're going to start steroids, and that is going to partially treat the leukemia, and then the child is going to land up as a high-risk category for treatment from the leukemia point of view, and that we're going to do a big disservice to the child. So we should not be starting steroids even if you have a slight doubt of malignancy. Apart from malignancy, then PID, inflammatory bowel disease. The other diseases, autoinflammatory syndromes, they're all very, very rare. So management of systemic JA, first line would be NSAIDs, particularly working up the child for a diagnosis. NSAIDs, non-steroidal anti-inflammatories, and we commonly use naproxen, 10 milligram per kilo per dose, twice a day. But that alone may not be enough in many cases, and that we can only use it in working the child towards the diagnosis. Once we have made the diagnosis, then we can decide upon how, depending on how sick the child is, you can go for IV steroids initially, 10 to 30 milligram per kilo for 3 to 5 days, then followed by oral steroids, 2 per kilo, and then we can slowly taper it off. Some of these children can be monocyclic, and suppose so far they may not actually need methotrexate. We can start with steroids, wean, and see what is happening. But for a child who's got established systemic JA, who's come in well into the disease, like coming after 6 months, 1 year, there's no point in giving steroids, and you need to start a second DMARD, a DMARD, methotrexate. And I prefer subcutaneous methotrexate for these children, because the concentration, the serum levels will be a little more higher compared to oral methotrexate, and for subcutaneous is preferred. Biologics, which is actually sort of preferred treatment in the West, in America and the USA particularly, they actually advocate use of biologics even as first line. Anti-interleukin-1, anakinra, is available selectively in our country, but we don't use it here because of the cost, and we only use it in specific situations like macrophage activation syndrome in systemic JA. Anti-IL-6 is available, like that is tocilizumab, what we gave for this particular child. It is expensive, and the subcutaneous form is also available, which we can give. And now that means that we can avoid the problem of repeated admission to the hospitals. And if at all they don't respond to any of these modalities, then autologous stem cell transplant is. But again, the prognosis, we don't know. It can be, the last thing that I remember was in Great Ormond Street in London, 50% had mortality, those who underwent transplant for systemic JA. So in our country, apart from steroids and DMARDs, we also use combination DMARDs, like we used in this child. We use methotrexate, thalidomide. Sometimes we even add a third drug like leflunomide when you can't get the arthritis under control. In fact, this is just a slide to show you that, the green underlined, I have showed you that this is the American College of Rheumatology guidelines for the treatment of systemic JA. In fact, they advocate even the treatment with interleukin-1 and interleukin-6 as they are conditioned recommended even as initial therapy. Whereas in the UK, they would still use steroids and methotrexate because it's NHS funded, it's government money, they still use steroids and methotrexate. And then if they don't respond, then they go to biologics. Whereas in USA, it's insurance based and they would go to anti-interleukin treatment. We need to remember the chronic side effects of steroids, because most of our children who are treated actually tend to get treated with steroids again and again. They get steroids, they get weaned off, and then once the disease comes back again, they get more steroids, and that is what should not be happening. This is just a huge list of complications that a child can possibly develop. So we need to be careful about using steroids. And to minimize side effects, what we need to judiciously use them, select the appropriate steroids. Use initially, actually, we need to, if it is systemic JA, give IV steroids so we can bring the disease rapidly under control rather than starting with oral. And we need to introduce DMARDs early in the course of the disease, and the appropriate dose has to be used and in the correct route. For example, methotrexate, give subcutaneous to start with, not oral methotrexate. and the appropriate dose also. So many times we see big children coming only with 2.5 milligram of methotrexate once a week, and that is like giving a ants dose. So it's very, very low. And in our situation, we can use combination biologics, combination of DMARDs, when the children can't afford biologics. And very, very important is we need to monitor the children for side effects. And like, for example, this child, this child was treated by an adult physician, and so they were not actually looking into from an adult point of view. I think they probably don't look at the child didn't actually grow. They were only looking at the symptoms. And so therefore this child only ended up only with steroids. So monitor for side effects and reduce side effects by appropriate intervention. For example, with steroids, make sure that they're growing, make sure that they get calcium, vitamin D supplements and so on. And monitor growth chart, extremely very important. That's the end of my talk. Thank you.
Thank you, Dr. Mahesh. I think all the discussions we'll do at the end so that all the panelists will be involved. We'll go to the second case, Dr. Fanikumar, sir. Can you please start? He will be presenting a case of juvenile dermatomyositis.
Hello. Hello.
You're audible, sir.
Yeah. I think I am the odd person in the group for the night webinar. I think I am the only adult physician among the group and the rheumatologists. But still, I think I take privilege because working in NIMS, I think we are well versed with most, because pediatric rheumatology is a yet to coming branch, and I feel adult rheumatology is in the same pace with the number of rheumatologists per year are around 50 per year, which are the new students coming up. So I feel pediatrics need more and more, because we too see a lot of difficulties when we manage pediatric case regarding the counseling, the parents, the transition care from childhood to adult. So a lot of things should be taken care in their growth part. And a lot of spectrum is so different to immunodeficiency, autoinflammatory syndrome. They can mimic it, and malignancies, childhood malignancies can mimic. So definitely I feel pediatric rheumatologists, I think the number should grow. And I'm happy to see Dr. Kavita, because she's our first pediatric fellow in rheumatology, which I think she passed out end of last year. So I'm happy to see her here. So without taking much time, Happy New Year to all, and thanks for the PAT for inviting me for this and giving this opportunity to talk to an unique group of people with pediatricians. So yeah, so coming to my presentation, I thought when a call came from Dr. Yashwant, so I told him I should be taking a topic of my interest. So myositis spectrum is of my interest. So I thought I will select a case from with a inflammatory myositis. So going with my case scenario, she's a 9-year-old girl who
excuse me, sir. Please go, sir. Slideshow, sir.
Slideshow. Oh, sorry. Now it is okay. Yeah. And she's 9-year-old girl present to us with myalgias with proximal muscle weakness of both upper limbs, followed by weakness of proximal muscles of lower limbs for last 1.5 months. And she has erythematous skin rash for upper thigh, face, and right elbow. And she doesn't have no history of any pharyngeal weakness, no history of dysphagia or nasal regurgitation, and no history of any pain abdomen, shortness of breath or cough, no history of any alopecia, oral ulcers, or joint pain. And on clinical examination, she has a heliotrope rash. She has a Gottron sign on elbows, which I'll be saying in a discussion of this case. And she has a calcinosis over buttock. And when we calculated her power by using manual muscle testing, MMT8, it was around 46/80. And rest of systemic examination was within normal. And this is where she presented to us. So with severe neck muscle, truncal, and the proximal upper limbs and lower limbs. So on evaluation of this girl, I think her hemogram was normal, and her AST and AST was elevated. It was 139, and creatinine was normal. And her CPK was elevated with the 2173. And when we did the myositis blood, she is NXP2 3+ positive, and her ANA blood showed dense fine speckle pattern, which is 3. And we started, I think she came to us in May 21. Before that, she was an outside follow-up with prednisone, which is 1 milligram per kg, with around 30 milligram with methotrexate increased from 10 to 20. By the time she came here with the weakness, which I shown you in the video, so we thought we should start her on rituximab. So upfront rituximab because of having already 3 months of steroid not responding. So we started on rituximab in May 21, and we had a follow-up of around 1.5 years. I think the last follow-up is in December, and you can see how our MMT8 has improved, which is an upper limit is 150. So she's totally fine after I think 1.5 years. I think she responded well to the rituximab and the methotrexate steroid. And the CMAS is another assessment tool where we use in childhood for myositis spectrum, and which to improve to normal, which is a score of 52. So this is a present video. So how she is, I think she's able to get up her own with mild hip muscle weakness. So our final diagnosis was juvenile dermatomyositis, NXP2 antibody positive with no extramuscular manifestation, and she's having clinically inactive disease with the power and everything she regained back, and she has a one complication which is calcinosis cutis on buttock. And coming to approach to muscle weakness, whenever we see any case with muscle weakness, this may be uniform for a neurologist, pediatrician, for anyone if a kid comes to them. The pattern of muscle weakness, whether it is proximal or distal, because that makes the differential. That is symmetric or asymmetric, where the disturbances are more asymmetric in onset. So, and again, the extent, whether it's the limb muscles, pharyngeal muscle, neck muscle, facial and extraocular involvement, because facial and extraocular are very odd for inflammatory myositis. So definitely these things should be asked because they mimic dystrophies when they don't have a rash. So definitely the differential is very important because we treat with immunosuppression. So definitely we should be sure whether we are dealing with a dystrophy or inflammatory myositis. And myalgias, cramps, and exercise intolerance, when they have a metabolic bone disease, they should be asked in history itself. And the muscle enlargement, which is typical for muscular dystrophies. And the associated symptoms, which makes us a clue whether we are dealing with an inflammatory myositis. Mainly the skin involvement, like erythema on eyelids, which we call heliotrope rash, on the fingers, on the knuckles and tips, which we call Gorton papule, and upper chest, back, thigh. You see an erythematous rash and periangular erythema, calcinosis, skin ulcers. There are a wide variety of mucocutaneous involvement in IAM, mostly pertaining to juvenile dermatomyositis. And the G8 related, because the more vasculopathy in dermatomyositis, they will have a G8 involvement, mostly having an abdominal pain postprandial, which suggestive of mesenteric ischemia, and which may present with vomiting and melena. And respiratory related, most of very rarely the IAMs in children will be associated with an ILD, so they can present with a shortness of breath. And arthritis is part of JDM and are constitutional symptoms. And there's a huge list of differential diagnoses for when we consider idiopathic inflammatory myositis. As I said before, whenever there is only weakness without rash, the dystrophy should be considered, metabolic myopathy should be considered, endocrine myopathies, and drug-induced myopathy will be a least possibility in childhood. And other neurogenic disorders which can present as proximal weakness like myasthenia gravis, motor neuron disease should be excluded. And again, the infections which can present as myopathies, transient myositis, so that should be ruled out. So, and which are the points favoring inflammatory myopathies? As I said before, the onset is subacute to chronic, proximal weakness, predominantly painless, and myalgias are only 30% of total spectrum. And the skin involvement, which I said, the Gorton papule and heliotrope rash, which are more commonly seen in adulthood, but still there are specific cutaneous signs for dermatomyositis, and they will have a significant nail fold changes, cutaneous ulcers. As I said in the index case, calcinosis, which is more seen in juvenile dermatomyositis when compared to adult dermatomyositis, and the joint involvement, G8 involvement, and an ILD, which can be rapidly progressive or a chronic ILD. So whenever you see proximal weakness with any of this systemic involvement, mainly the skin followed by joint, GA, and lung involvement, so you should be suspecting inflammatory myopathy. Coming to the inflammatory myopathy spectrum, if you see this image, whenever the skin and muscle combinedly, it's very easy to diagnose with classical DM. And whenever there is only skin without muscle, we have hemopathic DM and hypomyopathy, but these are very rare in childhood. And when you come to polymyositis and including, but they're very much rare in children. So the most of the spectrum of idiopathic inflammatory myopathy in childhood is found by dermatomyositis, that's juvenile dermatomyositis, which makes about 85%. When you come to the overlap myositis associated with another connective tissue disease, mostly in children, they are overlap with scleroderma, which is contributes to 3 to 10%. When you come to polymyositis, which is only 2 to 8%, there are only weakness but without skin rashes. When you come to amyopathic, only the skin rashes but without muscle, which is very rare when compared to adults. And coming to juvenile dermatomyositis proper, is an autoimmune disorder of childhood that mainly affects the skin and muscle. It is most common, which I told in the previous slides, it contributes to 85% of childhood idiopathic inflammatory myopathy. And And as compared to adults, children are more likely to suffer from disease relapses and long-term complications. So which are very typical for a childhood dermatomyositis are most of the lipodystrophy, insulin resistance, calcinosis, and they have more of a systemic vasculopathy. And coming to this picture, so the clinical features, it varies from constitutional symptoms, as I said in the previous slide about the lung involvement with dyspnea, 73%, and gastrointestinal involvement around 30 to 40%. And the most important part is the weakness, which is seen in 95%, and arthritis is the other part, which is seen in around 60%. And when you come to the cutaneous signs, if you see the wide range being described in various pediatric cohorts of JDM, the Gotten papilla and heliotrope rash, which varies from 60 to 100%. When you come to the other things which are very common and should be a complication of a inflammatory myositis or calcinosis, which is in around 30% and very hard to treat. And the next is the lipodystrophy, so 10 to 14%. And this is only the picture to show how the skin signs vary, which is very important clue in a clinic to think of a dermatomyositis. If you see the topmost, they can have a facial erythema, they can have a heliotrope rash, so which is erythematous violaceous rash on the eyelids. And they can have a papillary rash on the knuckles, so which we call as Gotten papilla. They can have a palmar erythema. So this is the image to show calcinotic deposits. They can present with ulcers, and they can have a muscular atrophy and a focal lipodystrophy. And how juvenile cases differs from adult. So if you go with this table, only I need you to see the characteristic rashes, which are so common in adult DM, is very rare in children. They have a generalized erythematous rashes and ulcerative changes. And muscle enzymes, as in adults, we don't see a lot of elevations in muscle enzyme. That's a problem. And amyopathic is less common. And prognosis is better if you identify early and treat. When you come to malignancy and ILDs, which are more common in adult when compared to children, whereas calcinosis and vasculopathy, so these are very prominent features in children, juvenile dermatomyositis than adult. And how you evaluate these cases? We initially, when we suspect, we do muscle enzymes, which is CPK, LDH, we do liver enzymes and alveolase. And when the next plan we do is myositis line immunoassay, which has 16 antigens, so which has both myositis specific antibody and myositis associated antibody. And electromyography, mostly we avoid in children because it's an invasive procedure. And imaging, we do when it's a doubt for a diagnosis of inflammatory myositis. And in a known case, we do for a disease activity assessment in a follow-up. Either we do a whole body MRI or we do a thigh MR. And muscle biopsy, whenever we have a suspicion of a muscular dystrophy and they don't respond, refractory, if we are missing any case without any rash, but only myositis. So there, I think muscle biopsy has a role. And this is a myositis immunoblood, I think, which helps you in clinic. So if you do it and if any antibody is more than 2+ or 3+, will definitely give a clue that you are dealing with an inflammatory myositis. If you see this 16 antigen, so I just circled this, the COO antibody, PMSCL, PMSCL75, these are all with an overlap myositis. The rest are with myositis specific antibody. And in the children, most common are NXP2, TIF gamma, and MDFI in some cohorts. And this is because why we do these antibodies, they define the phenotype and they define the organ involvement. And they also define how they prognosticate over time. They respond, they are poor to respond to therapy. So these clues will be given when you do this antibody. And these are the 3 antibodies which are more common in juvenile dermatomyositis. The first one is a TIF gamma antibody. And these cases, other than the rash and proximal myopathy, which will be seen in all dermatomyositis, they see more of a generalized lipodystrophy and cutaneous ulceration. When you come to NXP2, other than the rash and myopathy, they have more calcinosis and they have more GA involvement. And when you come to anti-MDFI, which constitutes 6 to 10% population, but in Asians it is 30 to 35%. Other than the rash and the myopathy, and they have a less myositis when compared to other 2 groups. So they come under AD myopathic dermatomyositis. They have more ILD and they have cutaneous ulcers, very classical. And the treatment part, the goals of therapy in JDM includes control of disease activity, preventing systemic damage, and improving quality of life of patients. Treatment is mainly consensus-based, backed a little with high-quality evidence, just as in adults. So the steroids are the first play a major role in the treatment of JDM. We give pulse steroid to oral steroid based upon the severity of muscle weakness, and we treat upfront with an immunosuppressive agent to taper steroid very fast. So we treat either with methotrexate, mycophenolate, cyclophosphamide based on severity. And based on the severity of refractory relapsing disease, we treat with rituximab or IV immunoglobulin. So I will skip this. Yeah. So how to monitor and follow? The tools for monitoring are important because for assessing ongoing disease activity and response to medication. So we use two scales to assess the power. One is MMT8, the second is childhood myositis assessment scale, along with the physicians and patient global assessment. And muscle enzymes, because they drop fast and they don't correlate with disease activity, and most of the time in JDM they will be normal. So what are the outcomes of this patient? So early therapy can help in attaining remission in 30 to 50% of patients within 2 to 3 years of disease onset and limit long-term complication. The disease course can be monophasic, which is 40%. So single hit and go. So they're very easy to handle. But polyphasic course, which have a lot of flares in between, they consider 60%. And major sequel of JDM are, as I told before, subcutaneous calcinosis, lipodystrophy, insulin resistance are the major sequel of JDM. And mortality rate is 3.1%. And major functional impairment over years is 6.5%. Yeah, thank you.
Thank you, sir. Thank you. We'll continue with the third case so that we'll finish. We are, I think, slightly behind schedule. I call upon Dr. Kavita to present her case on lupus. Dr. Kavita?
Good evening, ma'am.
Yeah. Good evening.
Ma'am, still there
Yes.
is a problem. Can you share the screen, ma'am? I'll present.
Let me just see that. Okay.
Yes, ma'am. Good evening, everyone. Today I'm presenting the SLE approach. This is 2 years female child. Two-year female child born to second degree consanguineous with developmentally normal, symptomatic for 3 months, in the form of fever for 3 months, oral ulcers, and skin rash and skin ulcerations for 2 months, facial puffiness and abdominal distension for 1 month. Now I will discuss how to approach for this case. What is pediatric SLE? Pediatric SLE is the prototypic systemic autoimmune disease. It is characterized by multiple autoantibodies associated with a multi-system illness where any organ can be targeted. Patients often experience disease flares and more rarely remissions. Pediatric SLE patients typically have more severe disease than adults. Next slide. The classification criteria and clinical features of SLE. This is entry point is ANA titer should be positive to classify the SLE case according to ULR and ACR criteria. There are 7 clinical domains and 3 immunological domains. In clinical domains, constitutional, fever, hematological, leukopenia, thrombocytopenia, autoimmune hemolysis, neuropsychiatric in the form of delirium, psychosis, seizure, mucocutaneous non-scarring alopecia, oral ulcers, subtle cutaneous discal lupus, acute cutaneous lupus, serosal in the form of pleural or pericardial effusion, acute pericarditis, musculoskeletal joint involvement, renal proteinuria more than 0.5 grams per 24 hours, renal biopsy class 2 or class 5 lupus nephritis, renal biopsy class 3 or class 5 lupus nephritis. These are all clinical domains. Immunological domains are antiphospholipid antibody, anticardiolipin antibody, or lupus anticoagulant, low C3, C4 or low C3 and C4, anti-double-stranded DNA or anti-Smith DNA. So a positive ANA with a total more than 10 score indicates the SLE. Then the pathogenesis. The pathogenesis of SLE is multifactorial. There is dysregulation of innate immunity and defective apoptosis, defective netosis. These genetic and environmental factors activate the innate immune system. Innate immune system produce so many cytokines. Type 1 interferon is most significant factor to form the pathogenesis in SLE. This type 1 interferon will present to the T cells and produce so many inflammatory reactions. These T cells activate the B cells. B cells produce the plasma antibodies. These form the immune complexes. These immune complexes get lodged in the glomerulus to form the glomerular nephritis. In the vasculitis in synovium causes synovitis. This is type 3 hypersensitivity reaction. Pathogenesis is multifactorial. Next. The systemic features of lupus. Renal involvement is the major system involvement. Manifest as proteinuria, microscopic hematuria, hypertension, elevated blood urea nitrogen. Renal disease is the greatest contributor to morbidity and mortality in SLE. Other renal manifestations in the form of tubular interstitial nephritis, thrombotic microangiopathy, non-necrotic lupus vasculopathy, and lupus vasculitis. Next slide. Depends on biopsy. Lupus nephritis classified to class 6. Class 1, there is minimal mesangial lupus nephritis with no renal findings, normal urine analysis, normal creatinine levels. Class 2, mesangial proliferative lupus nephritis, mild clinical renal disease, microscopic hematuria, proteinuria, minimally active urinary sediment. In class 3, focal proliferative lupus nephritis, less than 50% glomerular involvement will be there. Clinical features as hematuria, proteinuria, nephrotic syndrome, hypertension, abnormal blood urea nitrogen, and creatinine levels. Class 4, next slide. Class 4, diffuse proliferative lupus nephritis, more than 50% of the glomerular involvement. In clinical features in the form of hematuria, proteinuria, hypertension, and low complement levels. Class 5, membranous nephritis, significant proteinuria will be there. In class 6, advanced sclerosis, lupus nephritis, more than 90% of the glomerular sclerosis. Next, mucocutaneous involvement. Ma'am, next. Madam, next slide. Yes, mucocutaneous involvement. About 50 to 80% of children with SLE has the malar butterfly rash over the cheeks, and discal lupus lesions, 5 to 10% of patients found. This discal lupus lesions we may found in the face, ears, and scalp. The lesions may heal with scar or atrophy. Discal patches on the scalp may result in scarring alopecia. Next, hard palate ulcerations and alopecia. This is vasculitic rashes over the palm. Livido-radicularis type of rash. These are all mucocutaneous manifestation of SLE. Then coming to the musculoskeletal disease. Arthritis is a present as symmetrical involvement. Both the large and small joints involvement will be there. But this is non-erosive type of arthritis. Next, neuropsychiatric involvement. 20 to 70% of pediatric SLE cases presented with neuropsychiatric involvement in the form of headache, psychosis, seizures. So in 1999, ACR separate the 19 separate disease NPSLE, that is central nervous system and peripheral nervous system. In central nervous system, that is next slide. Central nervous system, that is aseptic meningitis, cerebrovascular disease, demyelinating syndrome, headache, movement disorder, myelopathy, seizure disorders, acute confusional states, anxiety disorders. In these children presented with seizures, acute confusional states, and cognitive dysfunction, mood disorders also live there. In peripheral nervous system, there is Guillain-Barré syndrome, autonomic disorders, mononeuropathy, myasthenia gravis, cranial neuropathy, polyneuropathy. Next, pulmonary involvement. We will see the pulmonary involvement for 25 to 75% of pediatric SLE cases in the form of pleuritis, pneumonitis, infectious pneumonia, pulmonary hemorrhage, pulmonary hypertension, pneumothorax. If any child presented with SLE case presented with the chest pain, we have to think of pleuritis or any pulmonary hemorrhage, pulmonary artery hypertension. Then cardiac involvement. Cardiac involvement, 15 to 25% will see the cardiac involvement in the form of pericardial effusion, myocarditis, and we'll see the limb and sac endocarditis also. Like Kawasaki coronary artery disease also involved in SLE cases. Myocardial infarction also we can see. Next, hematological involvement. Hematological involvement is 33 to 75% of the pediatric SLE cases presented with the hematological. By seeing the CBP also, we can diagnose, we can suspect the SLE, anemia, anemia in the form of anemia of chronic disease, anemia of autoimmune hemolytic anemia, iron deficiency anemia, megaloblastic anemia, leukopenia in the form of neutropenia or lymphopenia, thrombocytopenia, immune thrombocytopenia, drug-induced infections, thrombomicropathic and antiphospholipid syndrome. GI manifestations, GI and hepatic manifestations, lupus, peritonitis, pancreatitis, ascites, enteritis, hepatitis, and cholecystitis. Vasculitis, usually you'll see small cell vasculitis in the SLE cases. Endocrine, hypothyroidism, hypoparathyroidism. Hypothyroidism is the most common endocrine manifestation in the SLE cases. Ocular, scleritis, episcleritis, retinal changes will be there. This is all systemic involvement. So it is a connective tissue disorder. It involves almost all systems. But at the time of presentation, 1 or 2 systems will be there. On prognosis, we can find the other system involvement also. So monitoring is very important to involve the other systems. The laboratory evaluation. Laboratory evaluation, normal baseline investigations like CBC to rule out anemia, thrombocytopenia, and lymphopenia. Baseline LFT, RFT, chest X-ray to rule out any infections, urinary analysis. Indicators of inflammation is high ESR, but normal CRP. If CRP is increased in SLE cases, we have to suspect any infection like serositis, arthritis. Autoantibodies, ANA. Indirect immunofluorescence technique is the gold standard method to predict the ANA levels. That is 99% sensitivity. And anti-DS DNA and anti-Smith antibodies are high specificity. Low complement levels for the diagnosis and measurement of the disease activity, we have to look the complement levels. Undetectable levels of complements we can see in homozygous genetic deficiency. Apart from this, laboratory investigation depends on system. We have to follow up the case. If it is NPSLE, we have to do the brain MRI imaging. So principles of management. This is general. Treatment by multidisciplinary team with pediatric rheumatologist. Assess the organ involvement at the time of onset. Assess the disease activity and damage index. Direct therapy to specific the disease manifestation that are active. Achieve remission with adequate immunosuppression. Therapy for the shortest time period and lowest possible doses. Maintain remission with minimal toxicity of drugs. Prompt recognition of aggressive treatment of flares. Counsel and education the parents and child is very, very important to maintain the drug compliance. These children has to maintain almost lifelong management of the drugs. So we have to educate the child as well as the parents regarding the disease as well as the drugs, to decrease the flares. Transition to adult care in late adolescence. The general treatment. Because the child is growth and development should be normal. So adequate nutrition we have to maintain. For cutaneous manifestation, avoid sun exposure, use sunscreen more than SPF more than 30. Aggressive treatment of infections, immunize the child with non-live vaccines. Live vaccines are contraindicated on child with immunosuppression. So non-live vaccines, influenza, hepatitis A, hepatitis B, HPV vaccine, meningococcal, pneumococcal, and COVID-19 vaccines should be advised to the child to prevent the infections. Calcium and vitamin D supplementations on steroids, folic acid with methotrexate. That is general treatment. Organ specific treatment. Organ specific treatment divides the minor organ involvement like mild disease activity and major organ involvement, life threatening involvement. In minor organ involvement, skin, mucosa, musculoskeletal, all these things, we have to use low dose corticosteroids, HCQ, and methotrexate as azathioprine. If it is a major organ disease in the form of lupus nephritis, class 3, 4, 5, central nervous system nephritis, NPSLE, myelitis, cardiac effusion with coronary artery involvement. In all these major organ involvement, we have to give IV methylprednisolone with immunosuppression in the form of IV cyclophosphamide or MMF or azathioprine. This is the cutaneous manifestations of SLE management. We have to give HCQ for all cases and topical steroids in 1% hydrocortisone or 0.1% becnomate. And if it is not adequate, we have to start immunosuppressive in the form of methotrexate or azathioprine or MMF. Neuropsychiatry SLE. High dose, first we have to start with the high dose corticosteroid. First, we have to differentiate the NPSLE, whether because of inflammation or any thrombotic or any anticoagulants required. High dose of, if it is an inflammatory process of NPCLE, high dose of corticosteroids and IV cyclophosphamide should be given. Maintenance therapy with azathioprine or MMF. Immunosuppressive agents and antiplatelet anticoagulants if there is any antithrombotic or antiphospholipid syndrome suspected. If it is a cytopenias, anemia, we have to give blood transfusions, or if it is autoimmune hemolytic anemia, we have to give high dose pulse therapies or IVIG. Leukopenia, we have to observe this always disease activity. Decrease the disease activity, then the count will be normal. In thrombocytopenia, if it is less than 20,000 count, we have to give IVIG or rituximab. If it is more than that, IV corticosteroid, methylprednisolone or MMF, we have to give. Next. This is lupus nephritis class 1, class 2. We have to follow regular follow-up with the urinary protein creatinine ratio. Class 3, we have to start glucocorticoids with immunosuppression in the form of mycophenol, MMF or azathioprine. In severe lupus nephritis, we have to give IV cyclophosphamide. In class 4, glucocorticoids with cyclophosphamide or mycophenol, MMF or azathioprine. Class 5, membranous form, glucocorticoid with calcineurin inhibitors or MMF or cyclophosphamide. If it is a refractory lupus nephritis, we can consider rituximab. This is SLEDAI score. We have to SLE disease activity index score. So in each presentation, we have to give the score to the baby. Based on this SLEDAI score, we have to adjust the management. If SLEDAI score is mild, that is in between less than 6, we have to continue the same treatment. If the SLEDAI score increasing, we have to add on other drugs, or we have to increase the same drug dose. If it is a severe more than 12, we have to give IV form of corticosteroids and IV cyclophosphamide. If it is not responding to that, we can go with the rituximab. This is based on SLEDAI. Mild, moderate, severe. Mild less than 6, 7 to 12 is moderate, more than 12 is severe. The first child presented diagnosed as diagnosed as pediatric SLE, subcutaneous, subacute cutaneous lupus, oral ulcers, nephritis was there, thrombocytopenia, anti-DS-DNA. Child was started with the glucocorticoids and MMF. After 3 months, the SPCR is coming down. After 6 months, it is normal. Now the child is doing good with the glucocorticoids and MMF. These are my references. Thank you.
Thank you, Dr. Kavita. We'll go on to the last presentation, Dr. Anjani. She will talk about Kawasaki disease.
Is my screen visible, ma'am?
Not yet.
I have shared the screen. 1 second.
Please stop again and do it, ma'am.
Yes, yes, I'm doing it. Now, sir?
Yes, yes. You can make it, yes.
Good evening, everyone. At the outset, I would like to thank IAP, PATS, and Dr. Yashwant, sir, to take this effort to highlight the importance of rheumatological diseases in children. So all the previous, my senior experts have spoken about the chronic rheumatological diseases in children, but I would want to talk about a disease which is very commonly seen by all the pediatricians, and it is a rheumatological disease which has an acute presentation. So I would be presenting the case details of a 2-year-old boy who's resident of Hyderabad. has presented with fever for 5 days and rash for only 1 day. His history goes like this, that he has a high-grade fever spiking up to 103 Fahrenheit associated with chills, 2 to 3 spikes a day. On day 4 of his history, he started developing erythematous rash all over the body. However, there was no other systemic involvement in the history. He was given oral antibiotics on day 4 of illness. However, there was no response, for which he has visited me in the OPD. His previous history, past history, development and immunization history were appropriate for age. On examination, he was febrile, had mild tachycardia, was extremely irritable. There was pallor. Cervical lymphadenopathy was noted on the right side. He had diffuse erythematous maculopapular rash as seen in this image on the trunk, and also some very mild conjunctival injection on the bilateral eyes. And a systemic examination was unremarkable. So the initial possibilities considered here were infection upfront. Apart from infections, we considered Kawasaki disease or post-COVID multisystem inflammatory syndrome in children, and the rash occurring just after the use of antibiotics. Drug reactions were also considered. His investigations, which were done on day 1, showed elevated inflammatory parameters, high ESR, CRPs, and some neutrophilic leukocytosis. He also had mild transaminitis. His infective workup, including the blood culture, urine culture, dengue, scrub, and also the COVID antibodies were negative. Keeping a possibility of Kawasaki disease and MIS-C, a 2D echo was done on day 1, which was absolutely normal. So on admission, he was initiated on antimicrobials. However, his fever continued to occur. In fact, it worsened. On day 2 of hospital admission, he started developing this red cracked lips and also strawberry tongue. Because of the clinical worsening in this child, we have repeated his parameters. We did a 2D echo on the second day, which showed the development of coronary artery aneurysms with a small size aneurysm, both the left coronary arteries. Also, his CRP has risen from 92 to 142. With this new symptoms and also the cardiac involvement, a diagnosis of Kawasaki disease was confirmed, and he was initiated on IVIG 2 gram per kg. However, though his fever has reduced, it has not disappeared. Neither the inflammatory parameters have disappeared, normalized completely. Hence, we had to take a call and give him further drugs. Infliximab was given at 10 mg per kg because there was cardiac involvement, and also IV methylprednisolone was given for 3 days. Subsequently, his CRP has come down to 5, TLC has improved, and also the coronary aneurysms have come back to the normal size. And he was discharged on day 8 of hospital stay on oral steroids and aspirin. When this child came to us on follow-up or 2 weeks, we could see this characteristic periungual peeling. So the final diagnosis in this child was IVIG resistant Kawasaki disease with coronary artery involvement. Coming to Kawasaki disease, the first description of Kawasaki disease dates back to 1967 when Dr. Towisaku Kawasaki described 50 cases in a Japanese journal. Subsequently, it has become one of the most common cause of acquired heart disease in children in many countries, and it is also the leading cause of vasculitis in India. The American Heart Association has proposed a diagnostic criteria which states that fever for at least 5 days plus 4 of the following features, that is conjunctival injection, cervical adenopathy, skin changes, rash, and mucosal changes. If any 4 of these 5 are present, then we can label the child as a typical or complete Kawasaki disease. Fever in children with Kawasaki disease is very characteristic. Hallmark, high grading, will never touch the baseline and is associated with excessive irritability. These are some pictures of conjunctival injection. The most characteristic feature of this is that this conjunctival redness is not conjunctivitis. It is not associated with any discharge, no exudate, and it would have a characteristic perilimbal sparing as we can see in the picture. Cervical adenopathy is also a common feature. It is a non-fluctuant swelling which does not respond to antibiotics, and most of the times it is unilateral in nature. And sometimes it could be a first presentation of Kawasaki disease, and it is called node first KT. We all are well aware of the strawberry tongue manifestations of a Kawasaki disease. Apart from that, redness of lips, dryness, fissuring, peeling, and bleeding of the lips can also occur. Rash in KD can take many forms, from diffuse maculopapular erythematous rash in our index case to urticarial rash, micropustular rash, carentiform rash, and even erythema multiforme rash can be present. Perianal peeling is a feature which occurs very early in Kawasaki disease in the acute phase. And one more pathognomic feature of Kawasaki disease is the reactivation of the BCG injection site, which can be seen in young children. The exact cause of this is still not known. Probably it is due to some molecular mimicry. A dorsal edema is a distinctive feature in Kawasaki disease. It is present in the first 1 week of illness. In the subacute phase, that is around after 2 weeks, there would be characteristic periungual deformation, which would start just below the nail bed in both fingers and also the toes. The most devastating complication of Kawasaki disease, which we all are scared of, is the development of coronary artery aneurysms. And we should always remember that the maximum peak of developing these aneurysms is in the 2nd week of illness. So if we do an echo at the first week, we are not just safe in ruling out that there is no coronary artery involvement. Repeated echoes are necessary in these children. Apart from aneurysms, in huge giant aneurysms, there can be thrombosis. Sometimes these children can have severe myocarditis leading to KD shock syndrome also. Though coronary arteries are the most common involvement, Kawasaki disease is also like a systemic vasculitis. It is also a medium vessel vasculitis where any vessel can be involved and it can present with multi-organ dysfunction. Coming to the diagnosis of Kawasaki disease, it is basically depending on the recognition of all the temporal sequence of events. The strawberry tongue can come and disappear. Later, the node can be present, or later the rash can come. So it's not necessary that all need to be present at the same time. So the criteria or the guidelines themselves say that a careful history may reveal that more than one principal clinical features can be present during the illness. And for this, it is the history is the main leading clue. And there's no pathognomic test for confirming diagnosis of KD. However, there are some supportive investigations. If we see a neutrophilic leukocytosis, thrombocytosis starting in the 2nd week, elevated markers of myocarditis like pro-BNP, elevated acute phase reactants, and some transaminitis, all are supportive evidence. Other thing we should need to remember here is that if we suspect a child of KD, and suppose there's a typical Kawasaki disease, we need not wait for a 2D echo to be done before starting the treatment of Kawasaki disease. Echo may be normal during the initial phase, repeated echoes may be done, and we should not delay the treatment of Kawasaki owing to the unavailability of 2D echo. Apart from the coronary artery involvement, myocarditis, valvular involvement, pericarditis can also occur. When we see a typical Kawasaki disease, it is easy to make a diagnosis. But however, if we see a child who's not fitting into the classical criteria, then comes the main problem. So in such children, there is a diagnostic algorithm. If the CRP and ESR are more than the cutoffs, like CRP of more than 3, ESR of more than 40, then we need to look into some other basic parameters. If 3 or more of the following are present, then we can consider it to be a probable Kawasaki and go ahead with treatment. These are presence of anemia, thrombocytosis, low albumin, high ALT, high TLCs, and a urine which is showing more than 10 WBC, or if there's a positive echocardiogram with coronary artery involvement, also we can go ahead with treatment of Kawasaki disease. So why is it important to treat Kawasaki disease? If we don't treat these children, the risk of developing coronary artery aneurysms is as high as 25%. If we treat them on time, then the risk falls down to less than 4%. So how do we treat? I'm not able to go to the next slide.
Can access, madam. Access is there, ma'am.
Okay. Patients with complete and so how do we treat? The ideal time is to treat within the first 10 days of onset of symptoms with IVIG 2 gram per kg as we did for this index child, and also to start on aspirin. Apart from these, if suppose a child comes very late to us after 10 days, if he has any coronary artery involvement and if he's having ongoing fever, elevated inflammatory parameters, then also we should take a call and treat this child with IVIG. Suppose a child is having giant aneurysm, apart from antiplatelet, anticoagulation also needs to be started. Our index case, which I have discussed, was an IVIG resistant KD. So we defined it as a child who has persistent fever even after 36 hours of giving IVIG infusion. So the treatment options in IVIG resistant KD are many. So we need to check depending upon case to case. Either we can repeat a second dose of IVIG, go ahead with steroids or TNF blockers like infliximab, or sometimes cyclosporin may also be needed. It is seen that sometimes only IVIG alone may not prevent the development of coronary artery aneurysms, especially in the children who are at high risk for developing coronary artery aneurysms. These are those who have very delayed diagnosis, extremes of age, infants or children more than 9 years, males generally have a higher risk, or if the symptom duration is more than 14 days, and if they do not respond to the initial IVIG and there is thrombocytosis of more than 10 lakhs and low albumin, are these patients who have high development risk of aneurysm. It is proposed that in patients who are at higher risk, treatment intensification at the onset, that is, give IVIG along with some other drug, will improve the outcome. These drugs can either be steroids or infliximab. In our Indian setting, I think steroid is a drug which is more economical. However, there's no published head-to-head comparisons whether we have to go ahead with IVIG or steroids. Coming to one of the last slides, I would like to say when to suspect KD in a child. In a child who has fever for more than 5 days, who has irritability disproportionate to the presence of fever, fevers with rash which do not respond to antibiotics, and fever with lymphadenopathy. Not all fever with lymphadenopathy could be related to an abscess. It could be a node first presentation of Kawasaki disease, especially if the node is non-fluctuant and non-purulent. And sometimes when children present to emergency in shock, it could be a presentation of Kawasaki disease shock syndrome as well. So I would like to highlight that it is a common childhood illness which is seen by all the pediatricians. We need to be beware of the young children, especially the infants who are at the risk of developing more coronary aneurysms. One of the most important thing I want to highlight in this case, though it's a simple case, is that we need to repeat the 2D echoes depending on the clinical scenario. Here the child was worsening, his fever was increasing, there was a new onset symptom. That is the reason we wanted to repeat the echo the next day, and there was a significant rise in the dimensions of the coronary arteries. And management of Kawasaki disease is a teamwork involving the pediatricians, the pediatric rheumatologists, and the cardiologists. Thank you.
Thank you, Dr. Anjani. You were very quick in finishing all the slides. Now, for all the panelists, I'm asking, each of you can give one point. What are the challenges in pediatric rheumatology? Dr. Mahesh, what would you say are the biggest challenges? One challenge you can tell.
Challenge, I would say mainly from the practice point of view, from the clinical point of view.
From the practice point, I'm asking. So because I am a pediatrician, so from the pediatrician point, I feel the diagnosis is usually delayed, and the referral
that is the challenge. The thing is actually
so,
that is the challenge. Yeah, diagnosis is delayed, and also the presentation to us sometimes is quite late. And that from the practice point of view, the time by the time the child reaches to us. For example, the patient that I showcased, it was like the child didn't see a pediatric rheumatologist for like 9 years. And so that's a very, very long time. So that's one of the challenges in practice. And from the clinical point of view, if you look at the cases which are presenting to the pediatrician, they are mostly febrile patients. And so in a tropical country, you would always think about infections first. And traditionally, if you look at our past history, we always think about TB. When children are not responding to our standard antibiotic treatment, we start to label them as possible tuberculosis. And so they end up getting a lot of antituberculous treatment. You would see so many of these children with the systemic JAA, with arthritis, you see as suspected TB, even though they're very clearly systemic, and they'll be on antituberculous treatment for a long time. Another challenge from our practice point of view is rheumatic fever. the incidence of rheumatic fever has actually come down dramatically. Once upon a time, it was the most common rheumatological problem, but now it is, you can hardly ever see. Actually, it's maybe one a year or something I would see. And we see still a lot of children with arthritis being branded as rheumatic fever. And from the practice point of view, we should never ever refer from the pediatric medicine department. We should never refer a child with joint pain to orthopedic department. It should be a rheumatologist who should see it. A child who's got a joint pain and raised inflammatory marker is a physician work, not a surgeon's work.
Yes.
And juvenile dermatomyositis should again go to the rheumatologist, not to the neurologist. So I think these are just, I think I'll give Anjani and others some more points. I mean, from the diagnosis, and they're challenging because they present late, and they tend to have more complications by the time they're already treated, and the availability of alternative medicine in our country, you know, presence of Ayurveda, Siddha, and all those things. So children, they tend to go to, when the moment you tell them there is a chronic disease, they go away to those people. They get treated with all sorts of poisons and then come back to blame us. So there's a lot of challenges, I think. There's some of them I've mentioned. I think others can say anything that they want to.
Yes, each of you, because I know there are so many challenges. Not easy when it is a new branch. Many people don't know about rheumatology. They know orthopedics more. So we have to educate that orthopedic means only surgical side. For all medical side of arthritis, go to a rheumatologist.
I
agree. Any child who's got a bone, sorry, just any child who's got a joint or bone pain and has got elevated inflammatory markers should never ever go to the orthopedician. That is a thing. They should come to rheumatologist. The orthopedician is only involved when they present late, when they have very bad deformities, they have very bad FFDs. Then, you know, for joint, just for joint stretch, to put them under GAs and stretching the joint, or if they need joint replacement, that should be at the end, not at the start. For what is happening, the reverse is happening. They come to go to the orthopedicians first and then come to us when the disease is very bad. So that sort of reverse thing is happening.
Yes.
Anjani, sorry.
Yes. So adding to Mahesh's opinion, most often, I think in last 6 months, I have seen at least 40% of the juvenile idiopathic arthritis children first land up to the orthopedician, then come to the pediatric rheumatologist. They're initially labeled as septic arthritis. What I just want to highlight is that when we label a child as septic arthritis, there's something we need to remember. The age of the onset, the number of joint involvement, and the general condition of the child. We have to see all of these. If a child is just coming to the OPD, walking, looks very stable, and has 2 or 3 joint involvement, it is very less likely to be septic arthritis, and then we need not refer them to a orthopedician. Coming to the challenges, the main challenge is the common symptoms with which a pediatric rheumatological disease manifests. The symptoms are actually overlapping with many other common diseases. So all of them will have fever, all of them will have some joint symptoms, and all of them may have some mild rash, which are often treated as urticaria or simple rash or simple atopy. It is the evolution of the symptoms that will give us the diagnosis. So a proper follow-up will only help us in making a complete diagnosis. Apart from the delayed diagnosis, the other major obstacle in clinical practice is the cost of the drugs. As Mahesh sir showed, if we start giving only steroids on and off, it's cost effective, but it has a lot of side effects. So once we want to bring them out of this morbidity, the next major burden is on the parents regarding the finances, and ultimately we also will not be able to treat them effectively.
Dr. Kavita, what would you say if you're in a tertiary referral center for pediatrics, how many cases of rheumatological conditions do you see per day? Do you think you can pick them up and manage them at the correct time? Like those are sitting in private institutes, delayed referral to a rheumatologist is a common issue. But if you're primarily saying pediatric cases only, would you pick up rheumatological cases more early?
Yes, ma'am. After I finishing this rheumatology fellowship, and now I'm practicing in Nilofer Hospital, now I'm able to pick up the cases early because of some knowledge I acquired from.
So how can we disseminate all this to, general pediatricians? They, when to pick up, what symptoms? Do we wait for 2 weeks for any of the symptom before we call that this is a rheumatological condition? Or 6 weeks? See, for JIA, we are saying arthritis of 6 weeks duration. So do we wait for 6 weeks before we call it?
Not all rheumatological causes will take, like Kawasaki is an acute presentation.
Kawasaki is an exception, yes.
Yes. In other cases, usually chronic presentations, definitely as Mahesh sir was telling that infections, tropical infections are, and tuberculosis, one of the DD for that those cases. So whenever any multi-system involvement is there, with continuous fever, any abnormalities in the CBP, then definitely we have to think of one of the possibility of differential diagnosis as rheumatology, as in the form of SLE.
Dr. Fanikumar, what would you say about myositis, dermatomyositis? How delayed presentation? When do they come to you, to NIMS?
Yeah, the same thing, because as said by Dr. Mahesh and Anjani, the delay in diagnosis will go on, because the people may land up with a general pediatrician, orthopedician. So by the time they come in, so the delay in diagnosis will definitely bear them up, because either using an inappropriate dose of steroid, if they identify, without using, as Dr. Mahesh has rightly pointed out, the steroid side effects. It is going on with every rheumatic disease. I don't pinpoint only to JEA, it will happen with every disease. So appropriate use should be must, and an early diagnosis. So the delay in diagnosis is one. I think the debate between this continues in adult rheumatology too, with the orthopedics and everything. I think that which we can't stop it. So I think only thing which we do as adult rheumatology is about creating lot of awareness program with general physicians. But definitely that has changed, because knowing the specialty, knowing the symptomology and when to refer, so that definitely helps. I feel in a pediatric rheumatology also, I feel such type of things among the general pediatrician awareness should increase. So then only I think the early referral and early diagnosis and preventing them from long-term morbidity, mortality, definitely it will help. I think the diagnosis is the key, and the early diagnosis in any rheumatic disease should be must before we start any treatment. And that should be only created with the huge population we have. I think a lot of awareness should be to the general physicians or general pediatricians or whoever it is, and they should refer them early.
Madam, I want to add one point.
Yes.
In clinical examination, usually we'll examine all systems, CVS, CNS, all the systems. But musculoskeletal system in examination, usually we won't do in pediatric setup. But make a habit of practicing that musculoskeletal system examination, then that is better to diagnose the case early.
Yes, as part of teaching also, when we say CVS, RS, CNS, but musculoskeletal is not being said, yes, we should start including that also. Yes.
Madam, when you asked about when to refer, no, Jay, I think the moment you suspect it, you should refer as early as possible, because you don't. The thing is, you should not wait for 6 weeks. Actually, when you think that it could be JA, you refer that time itself to the rheumatologist, because by the time then at the end of 6 weeks, at least then the rheumatologist can start aggressive treatment straight away, rather than going on to waiting. Except for systemic JA, obviously the duration is not 6 weeks, it's 2 weeks. But otherwise, if you have, when the earliest moment when you think about rheumatological disease, you refer. Another way is to actually, how to suspect this, when you think that you cannot explain, when you see a child and you don't know what is happening in the child, then you can think that maybe there's some person called rheumatologist, who can actually help. If you look at mostly the PUOs, the big systemic reviews which has been published, you can see that about 20 to 25% of the PUOs are actually rheumatological origin. So when you think that something is wrong with the child and you feel that things are not fitting in, multi-system involvement, then call the rheumatologist immediately.
So I can tell other challenges also. See, when there is a fever of unknown origin, what patients expect is within 1 or 2 days of hospitalization, they have to get a response. They are not ready to wait for the investigation. We cannot do all the investigations in one go. We go step by step. So they don't have the patience to wait. And another thing I just wanted to tell about acute rheumatic fever and arthritis. Rheumatic fever has come down a lot. But even today, I think whenever there is a major migratory arthritis, everybody is still thinking in terms of rheumatic fever. Even if there is no involvement of any cardiac involvement, no carditis, no endocarditis, in spite of that, because I have faced these challenges, because the cardiologist will also say this is acute rheumatic fever. I think we can highlight if there is involvement of the small joints, then we should start thinking of JIA, not
The problem is
rheumatic
JIA,
fever.
ma'am. Mainly the large joints are involved. The small joint involvement is less common. It is mainly in the rheumatoid factor, polyarticular type, where you get the small
Or
joint.
reactive, maybe reactive.
Yeah.
To
So I think in rheumatic fever, another thing is there is a problem with the criteria itself. If you take the criteria, then you will end up branding many of these children as rheumatic fevers. And also a lot of these children, when you see, particularly you see children from Northeast, West Bengal, Assam, they come with joint pain and they all get immediately an ASO. And then ASO is high and they immediately get branded as rheumatic fever, which they don't even have any fever also. Just some vague, it may be even a growing pain. And some of these children, they tend to have elevated ASOs all their life. They keep on they'll have like 200 ASOs done in the last 3 years and they'll all be high. And so they'll be getting 3 weekly injections. So it was not rheumatic fever at all to start with.
Yes.
So there are a lot of cases like that also.
That
there is a problem with the diagnostic criteria, and moreover, they made this adjustments for the developing countries and all. That is actually, again, that is not right. Again, I think that was made, though it was actually made. I don't think the rheumatologist was involved in making that criteria, and that is why it was someone from infectious diseases, something like that. I think that is what Dr. Suma also said. So I think that is why we have too many patients being labeled as rheumatic fever.
I think the rheumatologist should highlight these things and have their say in the diagnostic criteria. And one more thing about, I wanted to ask Dr. Anjani, now Kawasaki is a vasculitis, right? But unlike other vasculitis, the first line of treatment is IVIG. Why is that?
So this is a debatable question. It has been discussed multiple times in multiple stages. So initially, when Kawasaki disease was being described, there was a retrospective study where they have done a retrospective study and divided patients on depending on the treatment they have received. So IVIG, steroids, or some NSAIDs, or leaving the patients who have not received any therapy. During that time, what they have noted, this was way back in 1970s, just after Kawasaki disease was reported. It was done by Dr. Kato, who was one of the friend of Kawasaki disease. In this retrospective study, they have reported that patients who have received steroid had a more involvement of coronary artery aneurysms. So since then, steroid has gone into the backside of treatment of Kawasaki disease. So no one has made an attempt to use steroids upfront. And meanwhile, IVIG has become the standard of care. In 2017, Cochrane analysis, due to the short of time, I skipped that slide. There was a Cochrane systematic review where they have stated that all patients of Kawasaki disease should receive at least low dose of steroid, irrespective of whatever the coronary artery involvement or the cardiac involvement is. So this is probably just because of the retrospective study and IVIG being the standard of care. We don't just use steroids as a baseline.
Maybe there can be a study, because IVIG is again expensive for our population. Forget about second dose, even the first dose is many are not able to afford. Dr. Fanikumar, what would you say? Do you get patients who were pediatric arthritis now presenting as adults to you? So do you find more morbidity in them compared to adult rheumatology RA patients?
Yeah, because the same thing, because when there is no early diagnosis, because when they transition to adults, when they're more than 18 or 16, they usually come to an adult rheumatology clinic. But by the time, if they're lately diagnosed and with a lot of comorbidities with the steroid use and everything, we face day in and day out, because the early the diagnosis is the key, because we see very regular. We see both in the pediatric and who transition to adults, but we face every day the same issues with the delay in the diagnosis of every patient, most of it. But with the government sector, which we had license with the Nizams, with Nilofer, so I think we are today to see every day 20 to 30. So minimum of 20 to 30 of the childhood group every day. So we see a lot of spectrum of from immunodeficiency to a proper rheumaticus.
So what are the immunodeficiency cases that you are seeing? How are you diagnosing? And what about the treatment? Any of you can tell us.
I think first Mahesh and Nandini.
Okay.
Yeah.
The thing is actually in our department, the PADs are not seen by us. Actually, we have a separate unit for that. But what we do is when the patients present to us, based on the history and examination, sometimes we see that these patients are actually branded as rheumatological conditions. They're actually PADs presenting as presenting like rheumatic diseases. We have seen patients like that, and then they're branded as, for example, like JA, systemic JA, and all those things, but they are not actually that. And so those sort of patients, we make the diagnosis, but we hand over to the other department for management. We have a separate department in our hospital, and they're the ones who look after. For example, if it is SCID, then giving IVIG, or if they're planning for bone marrow transplant, all that, because the BMT comes under the hemato-oncology and BMT. So they will look after those patients. So actually, I don't look after them directly. Once a diagnosis is made, I hand over to them. So in that way, my involvement in their care is less compared to what they do in PGI, for example.
Dr. Anjani can tell us then.
Nowadays, the word primary immunodeficiency is actually replaced with inborn errors of immunity. So this is because these are immunological derangements which are known to play a role both in rheumatological and immunodeficiency disorders. So over the last 2 decades, this demarcation between rheumatology and immunology has been almost gone, because there are many monogenic disorders which present with the rheumatological manifestations. For example, if a systemic JI is presenting within less than 1 year, there could be an underlying autoinflammatory syndrome. Or if suppose there's autoimmunity presentation at a very early age, it could be an underlying manifestation of some of the primary immunodeficiency, or per se infection could only trigger this autoimmunity. So these inborn errors of immunity are the monogenic disorders in which there's not only an increased risk of infection, but also there's an increased inflammation, increased autoimmunity, increased risk of malignancy, and also allergies. All together, we call them as inborn errors of immunity. So the spectrum is huge. The most common being the antibody defects like X-linked A gamma globulinemia or common variable immunodeficiency, which not only presents in children, but also in adults. The most severe form is the combined defect, in which both the T and B cells are affected, like severe combined immunodeficiency, Wiskott-Aldrich's, and the phagocytic disorders, suppose like anyone having neutropenia or chronic granulomatous disorders or leukocyte adhesion deficiencies. These can present with various skin abscesses or oral ulcers in case of neutropenia. I have seen 2 neutropenic cases who have been just picked up with recurrent oral ulcerations. When we looked at the CBCs, which were done on multiple episodes, what we could identify is that there was neutropenia during each of these episodes. And the most, which is, I could say, not a very severe form of immunodeficiency, is the one in which there are complement defects. Complement deficiencies. The spectrum of complement deficiencies is also huge, ranging from early complement deficiencies, which can lead to very early onset lupus. So the case which Dr. Kavita showed could well be a monogenic cause of lupus. Given that severe oral ulcers, very early age of presentation, it could be a very early onset lupus, and it will definitely need a genetic workup. And the other spectrum of these inborn error of immunity is autoinflammatory syndromes per se. So these, as Sir said, these are not, they have intrinsic inflammation. There are no autoantibodies, but there's ongoing inflammation. They would be having non-infectious fever, which keep recurring, or they may have prolonged fever, some may have rash. So the spectrum of inborn error of immunity is huge, and it is evolving, and there are more than 480 disorders which belong to this group.
So in case we suspect any such case, can we refer to NIMS or to Nilofer? Where should we send if we suspect?
I think to add to that, I think for the last years, as a part of FPAD project, which NIMS is a center of it, and we have privilege to learn about immunodeficiency. I think in a year we get 250 to 300 referrals from Nilofer itself or other parts of Hyderabad for a referral to rule out immunodeficiency. And I think with the testing of the genetic testing and what are the preliminary testing, not about the functional assays which we have. In our lab, we have a routine flow cytometry, immunoglobulins, and then we test for mainly for the genetic testing, we go for exome sequencing. So with that, I think we are able to diagnose definite immunodeficiency in around 1/3 to 1/4 of the 250 to 300 what we refer. But definitely we don't have the services to go beyond for getting any functional assay, getting parental testing. So definitely we are facing problem. But as Anjani said, when we see our cases, definitely antibody deficiency is top. And next comes a combined immunodeficiency, then next phagocytic defect, they all follow. So, but I think with the help of Nilofer, I think when we diagnose with any B cell deficiency, so we send them for a free immunoglobulin there. So that is helping us a lot. Even minimum, I think we are keeping them out of infection and prolonging their life with infection-free period.
What about the cost of exome sequencing, Funny sir?
Exome sequencing, we outsource outside, sir, because we do it from MedGenome. Because from institute, we in a year we send around 100 samples. So that is the reason I think they do for us at a price of 13,000.
Is there any registry regarding KD or any other disorder? Do we have any scope to do a registry in Telangana?
As of now, we don't have a registry, sir, but I think definitely we should go up with a KD registry. And I think Kawasaki disease is mostly, as I said, a pediatrician's case. All of us see together and manage. If we make a common registry for all the pediatricians, pediatric rheumatologists, we will have huge numbers.
I think Fanish has to take the lead, and Anjani madam will join along with Kavita.
For KD, I think we should not put emphasis only on the coronary size in the first week. So we'll get more number of cases if we do the 2D echo in the second week. Otherwise,
I think you can add Nageshwara sir along with you. You will definitely get lot number of cases with Nageshwara sir.
Yes, sir.
And lastly, there is a question from Swami asking, why is CRP low in SLE and ESR high? I think it is off the way. CRP will be very high in SLE compared to if there is renal involvement. Is it so?
Actually, in SLE, because of autoantibodies to CRP and defective apoptosis, these two reasons will explain the low CRP levels in the SLE, sir.
Okay.
SLE is actually an interferonopathy, sir. So these interferons increase in number, like how Dr. Kavita has shown the pathogenesis. So these interferons actually block the IL-6 in the downstream. So once they block the interleukin-6, it ultimately reduces the level of CRP, or CRP doesn't rise. But there are some conditions in SLE where CRP rises. Like if there's serositis, arthritis, or a coexisting infection, then the CRP would also be high in the case of SLE.
And there is one more last question. What is atypical KD and how do you approach from a senior pediatrician?
So there's no definition of atypical KD. Any case which does not fit into the typical spectrum. Suppose we see a child with fever, rash, has the peeling, but is not fitting into the complete picture, or some other manifestation of Kawasaki disease, like I was saying, it is systemic vasculitis. So the symptoms range from CNS involvement, in which there could be aseptic meningitis, facial palsy, sensory neural hearing loss, sometimes arthritis, sometimes myositis, sometimes hepatic involvement. when we strongly clinically suspect it KD and they have these other manifestations associated, then we label them as atypical Kawasaki disease. The approach would be mostly like the approach which I've shown for the incomplete Kawasaki disease. The treatment algorithm would be the same.
So there is another question, how to differentiate growing pain from rheumatic disease?
Will I answer that?
Yes, please.
Yeah. So, I mean, basically the thing is with growing pain, the child actually looks very well. The pain occurs mostly in the evening and at night, and it's mainly in the lower limbs. And the typical presentation is that the complaint is mainly from the parents because they get disturbed at night. The child wakes up screaming and all that. The parents get disturbed. They do some massage. The child goes back to sleep. The child forgets completely everything. The next day morning is happy, roaming and running around. But the parents actually remember it because they have been disturbed from sleep. So a very well child actually complaining of, presenting with history mainly from the parents. The one way to differentiate actually will be from other causes of night pain, because rheumatic diseases normally do not cause night pain except CRMO, chronic recurrent multifocal osteomyelitis, or non-bacterial osteitis. No other symptoms will cause night pain. So if you say that the parents are saying that the child is crying with pain, I'm massaging the child and the child is going back to sleep, that is completely harmless pain. But if the child is screaming with pain, not getting better even with mother's massage, then there is something wrong with the child. Then that is when you need to investigate further. In rheumatic disease, only CRMO presents with the night pain. Normal JAA, juvenile idiopathic arthritis, do not present with night pain. So, for example, the way I differentiate is when I was going in the ward at night, one PG is saying the child is screaming with pain in the ward. And I'm asking why the child is crying. And the PG is saying that the child has been admitted for JAA for evaluation. Then you know for sure that this is not a JAA. That is probably a malignancy. Yeah. So that is the way of differentiating. And the other conditions which can cause night pain is benign. This is osteoid osteoma. That again can cause night pain. So that is a way of differentiating. But in the other conditions, the child will be obviously unwell during the day also. For example, a child with rheumatic JAA will have pain during the daytime also, or with leukemia will be unwell during the day also. They will not have only night pain.
Yes. What are the bad prognostic features of systemic JIA? Dr. Mahesh, I think you can take that also. Bad prognostic features of systemic JIA.
Features here, I mean, when they present with the arthritis very early, particularly with the wrist involvement, high counts, and for us making a late diagnosis, for example, all these are all bad prognostic features.
And also the presence of macrophage activation syndrome.
Yes. Some patients can present with that as a presenting feature without actually having even arthritis or rashes. And again, that can be one of the bad features.
Is fibromyalgia present in children?
Yes, but we don't call them fibromyalgia. We call them as some sort of chronic pain syndrome or chronic regional pain syndrome. Fibromyalgia is mainly, I think, it's from the adult rheumatologist. Anjani, do you use the word fibromyalgia?
Yeah, I think we use it. I think now the entity of juvenile fibromyalgia, I think you see the recent publications which have been for last 1 year. I think they behave similarly to adult, but the criteria what we use to diagnose in adult are mostly developed and validated in adult than in children. But most of the changes in the brain, the centers where they have pain hypersensitivity is more or less similar to the adults because of lot of stress in the childhood, any child abuse in the early childhood. So a lot of stresses, they all will lead to the fibromyalgia in children.
In adults, you have this multiple pain points and all that. In pediatrics, we don't come with that multiple pain points and all that.
Because that is the thing.
It can be even just one limb also. So in that way.
I think the criteria, I think it should develop to have a better diagnosis in childhood.
In children.
Over to Jagdish Chandra sir. Jagdish Chandra sir. Sir, Jagdish sir, kindly unmute yourselves.
We had a very interesting discussion where all the 4 participants and the moderator They highlighted all the important points, and the ultimate message which has got to go to everybody, all the pediatricians, is early diagnosis, prompt referral, early initiation of the treatment, follow-up of the complications of the disease, and management, and parental and family involvement in the treatment with a multidisciplinary approach. Even though the symptoms are, signs are very, and then there could be overlap syndromes over there, it is for us to have a keen eye on the investigation, on the clinical science more than the investigation. So it depends upon how we are going to manage this case, identify the case at the earliest, send it to the refer it to the rheumatologist so that they can immediately start the treatment. And delaying the treatment is going to cause long-term problems for the child, and also the response might not be that good. So we have had a very good array of cases which were discussed, right from dermatomyositis, juvenile arthritis, then we had juvenile rheumatoid arthritis, and then we had systemic lupus. So all these cases were very well discussed by all the our panelists, and the messages were very clear. So I think this the discussion which we had is going to instill a lot of confidence in our pediatricians also in diagnosis these cases. Even Kawasaki was discussed very well. So I think all the points have been put out very well by the panelists. And thank you for giving me this opportunity to hear to the panelists, esteemed panelists. Thank you very much.
I thank all the panelists for a wonderful presentation, and also PATS for giving me this opportunity. Thank you.
Is Vaidyam there? Today, people joined from Goa, Karnataka, Kerala, and especially Dr. Chandramouli sir. He joined from USA. He has a passion to be in discussion. And remotest parts of Warangal, which is around 400 kilometers, a tribal area, 2 people have joined. So it speaks immense interest in the topic, and the sensitization will definitely go in regarding the disorders. Thank you. Over to Vaidyam.
So thank you, sir. So it's my honor to give vote of thanks on behalf of PATS. I thank Dr. Upendra Kinjewardekar ji, National IAP President, Dr. Baswaraj ji, President-elect, Dr. Bhattacharya ji, Vice President, and our President Yashwant Rao, and today's chairpersons Dr. U.S. Jagadish Chandrachar ji, and moderator Dr. Rama Madam, and today's panelists Dr. Ranjani and Dr. Panikumar, Dr. Kavita, and Dr. Mahesha, and all the seniors and faculties and senior pediatricians, and past President Lakshman Kumar Surender, Dr. Surender Garu, and other viewers of today's webinar. And thank you to everyone.
Kindly post your pickup points for each case. If you could, probably we'll publish in our PediVoice so that it will help us. You put on your mails, they'll send you the questions or queries whenever required. So I request each and everybody to post the summary and salient points, what a common pediatrician should know. Thank you.
Thank you. Thank you all once again. Good night.
Good night.
Thank you, Mahesh sir.
Thanks.
Any comments, Anjay sir?
Excellent program. So far, I have been very educative program on rheumatology for the first time. It's a good program, sir.
Thank you, sir. Thank you, everybody.